Good afternoon, everyone. My name is Dalia El-Mafti, and I'm an assistant professor at the University of Chicago. And today we'll be talking about pain management and painful disease states. Now, for the past 15-20 minutes, we were talking about different types of peripheral neuropathic pain. We're now going to focus our attention on some of the central neuropathic pain syndromes, post-stroke pain, and spinal cord injury pain. Again, these are sometimes the most difficult types of neuropathic pain that can be managed. They're often severe in nature. A lot of times patients will present with a constellation of symptoms that can range anywhere from allodynia, hyperalgesia, or hyperesthesia. For patients who have post-stroke pain, it's on the side that the stroke has occurred. For example, if patients has ongoing weakness in the right upper extremity, a lot of times they'll complain of this severe burning pain and increased sensitivity along that extremity as well. Once again, this is a very difficult disease to treat, but multimodal approaches are indicated. We focused our attention on some neuropathic pain syndromes. Now we're going to discuss some somatic pain syndromes. And we kind of define somatic as pain that can occur from skin, muscle, fascia, tendons. So myofascial pain is a type of somatic pain syndrome. And basically with myofascial pain, it will not follow a dermatomal distribution. If it is following a dermatomal distribution, then this is not myofascial pain. There's been multiple changes to the definition of fibromyalgia, but it's usually defined as widespread pain that can include anywhere from 11 to 18 tender points when examining a patient. Tender points are usually identified by palpating certain muscles, and as you palpate, and there's an area of tenderness in that area. Trigger point injections are sometimes indicated, and they can help decrease some of the pain at that trigger point site. But what's most important for these patients is aggressive physical therapy and exercise program. The more we can keep our patients functional and active, overall the better they will do. There are medications that have been FDA approved for the treatment of fibromyalgia. Some of those include duloxetine and pregabalin. And again, we'll discuss these medications a little bit further in the presentation. Sacroiliac joint pain can also occur and is considered a type of somatic pain. It usually presents with pain in the lower back area. It often does not radiate. If it does radiate, it won't go back past the knee, and it radiates down the posterior aspect of the thigh. Most of the time, SI joint can be a source of axial low back pain. It's actually 15 to 30% of the etiology for low back pain. Again, the pain can radiate from the buttock to the posterior thigh, stopping at the knee. For the most part, treatment modalities include anti-inflammatory agents such as NSAIDs. Muscle relaxants sometimes can be useful as well, but most importantly is physical therapy and keeping patients active and functional. If patient does not respond to conservative management, at that point you can consider interventional treatments such as a sacroiliac joint injection. Now, the sacroiliac joint is a true joint and it does have synovial fluid, so sometimes doing injections that contain anti-inflammatories such as steroids may be beneficial. Spinal pain. When we refer to spinal pain, I often classify it as somatic or visceral. When I refer to somatic, again, as we mentioned earlier, that's skin, muscle, joints, tendons, bones. So when we're referring to the back, of course, we have muscles in our back. So somatic back pain can be myofascial in nature, or it can be related to the joints. Our facet joints are joints that are located in our back, and basically they are formed by the inferior and superior articular process. When we refer to visceral spinal pain, sometimes that can be, or the source can be nerve irritation We earlier talked about radiculopathies, and radiculopathies occur when a nerve root is being irritated either by a disc or some other process. Once again, when we refer to visceral spinal pain, it can be originated from disc pathology, such as a disc herniation. We'll talk a little bit about lumbar facet joint pain. Again, it can occur most commonly in the lower back or the lumbar facets, or in the cervical area, the cervical facet joint pain. With lumbar facet joint pain, as we mentioned earlier, it can be an etiology of low back pain. Anywhere from 10 to 45% of the patients may have this as an underlying source. Patients usually present with back stiffness that's worse in the morning, and again can radiate down the leg, but similar to sacroiliac joint pain, does not radiate below the knee. There can be tenderness in the paraspinal area over the joint as the patient moves or stresses that joint. With cervical facet joint pain, again, it is 60% of the reasons that patients who have chronic neck pain, it's a source of etiology. It can occur after whiplash injuries. A lot of times patients will complain of neck pain that can radiate to the shoulders or between the shoulder blades. Also, patients can complain of headaches. On exam, you may find decreased range of motion of the neck, and once again, tenderness over the joint as you stress that joint, meaning having the patient turn to the right, to the left, flex or extend the neck. With facets, they are innervated by the medial branch nerve of the dorsal rami at the level above and level below that respective vertebral body. We'll talk more about facet joint ejections in just a bit as we go over treatment modalities. We talked earlier about different types of visceral spinal pain, and again, when I refer to that, that means it could be a radicular in nature. With low back pain, it's been classified into acute, subacute, or chronic based on timeline. Acute back pain can occur if it lasts anywhere from 2 to 4 weeks. When it lasts up to 12 weeks, it's considered subacute, and when it lasts more than 12 weeks, it's considered chronic. History and physical exam is important to help identify, the affected nerve root. Oftentimes, patients who have underlying radiculopathy will be able to map out that nerve root. For example, if there's irritation of the L4 nerve root, they'll describe the dermatomal distribution, and the pain follows that dermatomal distribution, meaning pain that occurs on the lateral aspect of the thigh going into the medial aspect of the lower leg. Oftentimes, it can be associated with numbness, tingling, or muscle spasms. On physical exam, it's important also to do a focused neuro exam, meaning checking sensory exam, motor exam, and reflexes and special tests such as a straight leg test. Diagnostic tests that can help you identify etiology include MRI and EMGs, as well as they can pinpoint the level of radicular pain. Not necessarily indicated that you need an EMG, but oftentimes if the picture is confusing, it can help. If the picture is confusing, it can help you pinpoint the etiology. As with a lot of our painful disease states, a multimodal approach is important. Of utmost importance is physical therapy. Core strengthening is quite important in patients who have back pathology. As well, in certain disease states, anti-inflammatories can be considered, as well as some of our anti-epileptic drugs and certain interventions, and we'll talk about that later on. Now, cancer pain, it's a broad topic. Usually the underlying pathophysiology can be associated with the disease itself, as well as some of the treatment modalities. Chemotherapy, radiation can induce neuropathic type pain, and some of the comorbidities associated with cancer can also cause pain. So examples of that would be A patient that has breast cancer and had metastatic disease to the spine and to the liver, now has liver dysfunction, liver cirrhosis, that in itself can cause pain. Cancer pain can also be acute or chronic in nature. Acute, if there is an acute injury. For example, we'll go back to my breast cancer patient who has new mets to the spine that cause a compression fracture. That compression fracture is an acute type of pain, but she still has the ongoing chronic pain from the breast cancer and the chest wall pain. It can also be nociceptive or neuropathic. We talked earlier about nociceptive pain, and basically that means is a noxious stimuli stimulating the nociceptors. Perfect example of that was what I mentioned earlier, the compression fracture that occurred. So now we're going to go in and discuss some of our treatment modalities when treating pain. So the World Health Organization came out with the stepladder approach back in 1996. And it was initially introduced for cancer pain, but now it's been adopted for non-cancer pain as well. And basically the whole concept of this was to help physicians pretty much figure out where to start when it comes to pain management. Step one is considered a patient that has mild pain. And at that point, when patients have mild pain, more conservative measures are recommended. And that's why non-opioid or adjunct medication is usually recommended, as well as physical therapy. For patients who have mild to moderate pain, that's where you would start off at step 2 of the ladder. Opioids can be considered plus or minus, and adjunct therapy should be considered. Patients who fall on ladder 3, step 3, those are usually patients who have severe pain. And again, opioid management is indicated, or stronger opioids are indicated, as well as adjunct therapy. This will lead us into our next topic. A 58-year-old man undergoes open reduction internal fixation of the left femur without complications. Which of the following regimens would be the best choice for postoperative analgesia? Is it A, scheduled acetaminophen, scheduled oxycodone, and lidoderm patches? Or B, as needed oxycodone and cryotherapy? Or C, a hydromorphone patient-controlled analgesia, otherwise known as PCA, and lidoderm patch? Or D, scheduled acetaminophen, cryotherapy, lidoderm patch, and a hydromorphone PCA. The correct answer is D. Well, why is the correct answer D? Because really what they're trying to get at is a multimodal approach. In general, when we're managing pain, using multiple agents to control pain is usually recommended. With D, not only are we using medications, but we're also using some topical analgesics, as well as cryotherapy, which is really cold therapy. The other A, B, and C are not necessarily incorrect, but what's most correct is that multimodal approach. And again, we use multiple options to help minimize side effects of each individual drug and hopefully maximize effectiveness. So that leads us into our discussion about opioids. Opioids were initially used back in 3500 BC. Or actually, Incas used to chew poppy seeds and spit in the wound of the warriors. And basically what that would do was provide opium, which is what opioids are made from, and provide analgesia to the warriors that were wounded. The pure substance morphine was isolated in 1806, and now we have several other derivatives and synthetic analogs. When we refer to opioids, they usually work on opioid receptors that are opioid receptor agonists. And we have different types of opioid receptors. We have the mu, kappa, and delta. Now, all these opioid receptors are linked to a G protein, And basically when that G protein is activated, it helps inhibit the release of neurotransmitters or excitatory neurotransmitters that can lead to pain. The opioid receptors are predominantly found in the dorsal horn, dorsal root ganglion, but also in peripheral nerves. This table here shows the different types of opioid receptor, the mu, kappa, and delta as seen on the left. Each of these receptors have a subtype, and they have different locations where they can be found and different functions. So we're going to quickly go over some of the receptors and location and function. So delta, it has different types of subtypes, delta 1 and delta 2. They are found both in the brain and peripheral sensory neurons. They provide analgesia, but also have some of the side effects from opioids, which means physical dependence and antidepressant effects. And we'll talk about that in just a bit. Kappa, there's different types of subtypes as well. There's kappa 1, kappa 2, kappa 3, and those are found in the brain, peripheral sensory neurons, as well as spinal cord. And they provide analgesia, but also cause sedation, meiosis, and inhibition of antidiuretic hormone, ADH, as well as dysphoria. Mu receptors, there's the mu1, mu2, and mu3. mu3, we still don't know the exact function of it. But these receptors, the mu receptors, can be found in the brain, peripheral sensory neurons, spinal cord, and intestinal tract. Now, because they're found in the intestinal tract, specifically the mu2 receptor, that is usually the causative reason why we can have decreased GI motility and constipation. mu2 has also been implicated in respiratory depression and physical dependence. mu1 is responsible for the analgesic properties of opioids as well as physical dependence. And as we mentioned earlier, mu2, the mechanism is unknown. When we refer to opioid therapy, we usually mention acute opioid therapy versus chronic opioid therapy. With acute opioid therapy, there is literature there that shows that it can be beneficial for postoperative pain management. But there are also side effects associated with acute opioid therapy. Most common side effects include the constipation, the nausea, the vomiting, the respiratory depression, of course sedation, and a more relevant phenomena that's been occurring these days is opioid-induced hyperalgesia, when opioids actually cause pain rather than prevent pain. Again, this phenomena, we don't completely understand its underlying mechanism. It's thought to be maybe to activation of the N-methyl D-aspartate receptor, otherwise known as NMDA. Itching is also a common side effect that can occur with opioid therapy. It's more common with intravenous opioids and neuraxial opioids rather than oral opioids. Important thing to know about the opioid that you're administering to your patient is how it works. Patients will respond to different types of opioids. Number one, because of the organ dysfunction that may occur and the pharmacology related to that opioid, as well as genetic predispositions. I'll give you some examples here. Both morphine and hydromorphone, they undergo hepatic metabolism and they're excreted by the kidney. So if a patient has kidney dysfunction, issues may occur, meaning there can be accumulation of morphine 6 glucuronide, which is an active metabolite. What can occur in patients who have renal dysfunction is that it may not be cleared, and as I mentioned, it's active metabolite and is responsible for 50% of the analgesic response. If it's not cleared, then patients might be overdosed, and that can lead to respiratory depression. Morphine 3 glucuronide is also an active metabolite. It does not provide analgesia, but it can be a proconvulsant. So once again, in a patient with chronic renal insufficiency or end-stage renal disease, you must be cautious with morphine, as accumulation of this metabolite can lead to convulsions. Earlier, I mentioned that there's genetic predisposition to certain opioids. There are some patients, 10% of our Caucasian population, are considered poor metabolizers to certain medications that are certain opioids that rely on cytochrome 2D6 and the cytochrome 450 system. Codeine, oxycodone, and hydrocodone. In patients that are poor metabolizer, basically that means that the medication is not being metabolized into its active metabolite, and so there will be no response or a poor response. On the other hand, there are patients that are ultra metabolizers, where they will metabolize codeine, and that can result into an exaggerated response to the opioid. Other medications, such as fentanyl, methadone, they're metabolized by the cytochrome 3A4 system. And if patients have deficiency in that, they may alter their metabolism as well. Patient-controlled analgesia. We talked about opioids that can be administered intravenous, neuraxial, orally. Patient-controlled anesthesia is something that can be used on an inpatient basis. There are benefits to patient-controlled anesthesia, one of it being improved patient satisfaction, because patients don't have to wait for nursing staff to go get the IV medication from the Omnicell and double check it with a nurse prior to it being administered. Sometimes that can take a 30 to 40 minute process depending on the institute that you're in. As well, with patient-controlled analgesia, patients have an IV, and the medication will go directly through the IV. That'll avoid any painful injections, such as IM injections. Patients can also self-titrate the medication, meaning if they're in pain, they can press the button, but if they're not in pain, they don't need to press the button. Or if they're getting too sedated, obviously they won't be able to press the button, and in a sense, it can help eliminate sedation. But it is important when patients are on patient-controlled analgesia that you tell family members not to press the button for them. As well, in the pediatric population, you need to determine whether or not the patient has enough cognitive ability and understanding of how the PCA works. There is some literature out there, again, as I mentioned, that patient-controlled analgesia improves patient satisfaction and is superior type of postoperative analgesia compared to PRN dosing. This was a Cochrane database review that was conducted that found these similar findings. This will move us on our next topic of discussion. We're referring to that same patient. The patient responds to postoperative medication but has persistent severe pain and persists at a clinic follow-up visit 6 months later. He continues to take oxycodone 20 milligrams by mouth 6 times a day, and he admits that he's taking up to 10 a day because his pain is so severe, and he's requesting another dose increase. Regarding opioid pain medication for chronic pain, which of the following is most likely true? A, only 70% of the patients demonstrate significant benefit at 12 months. B, patients should be informed of risks of long-term opioid therapy. C, endocrinopathies are extremely rare. Or D, combining benzodiazepine results in dose reduction and increased safety. The correct answer is B. The patient should be informed of the risk of long-term opioid therapy. Now, I mentioned earlier that there's literature out there that shows that yes, opioid therapy is beneficial for acute pain, but unfortunately, the literature does not show any benefit for long-term use of opioid therapy. No improvement in health-related quality of life or activities of daily living has been identified. A is incorrect. 70% of patients demonstrate significant relief at 12 months. I just answered that question. C, endocrinopathies are extremely rare. Actually, that is incorrect. Hormonal deficiencies do occur with chronic opioid therapy. And D, combining benzos with can result in dose reduction. That's actually incorrect. That can increase the risk of respiratory depression, because we know our benzodiazepines can be sedative, as well as combination with opioids can result in an increased risk of respiratory depression. Again, regarding opioid efficacy, we mentioned that randomized controlled studies and observation studies have shown that opioids can be beneficial in acute pain, but there isn't any supporting evidence for chronic long-term pain. There's an epidemiological study done in Denmark. About 2,000 patients were enrolled, and they found that actually patients that were taking opioid for long-term treatment reported more moderate to severe pain, as well as lower quality of life scores. And they had lower levels of physical activity as well. So chronic opioid therapy, it's an important discussion that you have to have with your patients. If patients aren't benefiting from the opioid therapy, then it should be discontinued. Patients also should be informed of the risks of chronic opioid therapy. Tolerance can develop as well, and another phenomenon that we talked about earlier, opioid-induced hyperalgesia, where the pain medication also actually causes pain rather than resolves the pain. When we're talking about chronic opioid therapy and some of the side effects, you do not develop tolerance to the side effects with opioid therapy. So there will be no tolerance to constipation. It will still be maintained. There are hormonal and immune effects of chronic opioid therapy that need to be discussed with patients. As we mentioned earlier, the hypothalamo-pituitary tract and gonadal axis can result in lower testosterone levels in patients, which can be problematic. Lower estrogen levels as well. They can both lead to infertility and decreased libido. And regarding the immune function, there's increased literature out there that shows that opioids may be related to progression of certain cancer states. A lot of it is animal literature. Human literature is still pending, but that's something that we need to consider as well. There's certain phenomena that can occur in patients who are on chronic opioid therapy. One of those is the opioid tolerance. And basically what opioid tolerance means is requiring escalating doses to maintain the same drug effect. Really what's occurring is there's a shift to the right of the dose response curve. You need more medication to get the same effect. And unfortunately, with dose escalations, this can lead to side effects as well. You can still have the sedation, constipation. And one thing you need to be careful before you start escalating these doses, especially in acute postoperative pain or even in chronic pain in patients who have disease states, you need to first ask the question, why am I increasing the dose? You have to exclude any functional causes or disease progression as well. Physical dependence, you need to be very careful when describing physical dependence versus psychological dependence. Physical dependence basically means when there's the absence of the drug in the system, patients will develop abstinence syndromes or withdrawal symptoms, which sometimes can be presented as nausea, vomiting, chills, and aches. This does not necessarily mean that they are addicted. Addiction is a type of psychological dependence, and with addiction, yes, withdrawal symptoms can be present, but it's more an abnormal behavior or craving for a drug other than relief, and patients will go to extreme measures to be able to obtain the medication, meaning stealing, committing crimes. And of course, this can lead to a lot of effects on their life, meaning losing their job and even incarceration. Pseudo-addiction is an iatrogenic phenomena. We have to be careful with our biases as physicians. There are patients whose behavior may suggest that they are addicted, but actually it's our poor managing of the pain. And again, most important thing to help prevent that is performing a good history and physical exam and observing your patient and the response to the medication.